Thank you very much. First, a warm welcome to all. With God's grace and blessings, let us all, as Sri Priya mentioned, let us all walk together in this attempt of learning more. Learning is always to happen and finally achieve our goal of doing best service to mankind. Okay, let God's grace and blessings be with us for all of us to be successful in this venture. At the outset, first, thank you to Palliative India, and then a warm welcome to Dr. Sanghamitra Bora. We have immense pleasure and privilege for having you as faculty for this session. A brief introduction about her. She is one of the lead person for Assam Cancer Care Foundation. And on top of all her other qualifications, she's also obtained her MSc in Palliative Medicine from Cardiff University. And not the least, she's an active member in many national facility faculty systems. Few of them are, she's one of the member for the IAPC, and she's also an active trainer for the Ministry of Health and Family Welfare. And she's an active member in palliative care and a close friend to Palliative India too. A warm welcome, madam, to enlighten us on this session. Thank you. Over to you, madam.
Thank you so much, Dr. Radha. Thank you so much, Sri Priya and Palliative India for having me here. Unfortunately, I'm still on my way back to my office. Pardon me if, at points you hear the sounds of vehicle or, honking of horns. But I would like to, start the session as planned. That is why I do not want to delay by another 10-15 minutes. I would like to switch off my video so that you don't get distracted by the vehicles that that are actually traveling beside my vehicle. But having said this, there is a turbulent environment here in Guwahati at present because of heavy rain. And I may get disconnected from you also because of the unstable net connection that I have been having. But I would want to do justice to this very introductory session of palliative care, and would like all of you to take back home a very important message today, which is developing compassion along with a lot of skills that are required to deliver the best of care to your patients in your own facility. So I would like to share my screen. So is this screen visible to everyone?
We are getting the message that you have started screen sharing, ma'am, but the screen is yet to.
Hello?
Yes, ma'am. Screen is visible. Just we need to put it on the slide.
Okay now? Is it okay?
Yes, ma'am. Perfect. Good to go.
And can you all hear me properly?
We at the hot side can, yes, Dr.
Yes, we can hear. Go ahead, madam. We can hear. Go.
Okay. So you as doctors, I know all of you are very inquisitive about this, has been going on since the time. The question of the best possible care to all the patients that we generally see in our OP. Wherever we are, whether we are anesthetists or surgeons or involved in oncological care or long-term care, as neurologist or even general physician. So I know about this particular definition that has been given by the WHO, which generally is an approach, and we aim to improve the quality of life of patients and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering. And this generally is, includes the treatment of pain and other problems, physical, psychological, and spiritual. So about the proper definition of palliative care given by the WHO. So, what is the history behind the palliative care development in India? So, in the olden days, traditional health care used to be always in the home of people. We all know because there used to be just one doctor, perhaps in the vicinity of around 1,000 people in a village or in a hamlet. And then that particular doctor used to go to people's homes and provide all kind of care that is required, and that was the traditional healthcare system of India. But as the old and the dying
Dr. Sanghamitra?
Cannot see the screen.
So I was actually talking about the history of palliative care in India. So as we all know, the traditional health care used to reach people at their homes, and barefoot doctors or doctors who were practicing in one locality used to visit patients at their homes, and that would actually mean that everything would be taking place in the homes of these patients. And in contrast to this, in the West, the old and the dying were cared for in hospices. And the word hospice actually, comes from the Latin word, which generally means a care home where people used to be taken during the last months or last weeks of their lives, and they used to be cared for at the end of life, and then they used to, generally die in those particular places, and those were named as hospices in the West. So modern palliative care was started by Dame Cicely Saunders in the UK, and she is regarded as the mother of palliative care in the world, and she started the modern palliative care movement. In India, palliative care started in the 1980s, and that was mostly as NGOs taking much more part in bringing in palliative care activity in the country. And you all must be knowing that the southern states of Kerala and uh, Tamil Nadu, those states were generally they used to have a lot of palliative care activity on behalf of the NGOs, numerous NGOs that were working in the society, in the communities to deliver palliative care. Mostly, concentrated to deliver palliative care for the people who were dying, who were having terminal illnesses like cancer or long-term illnesses, kidney failures, etc. So, what is it in contrary to actually popular belief? It is not only for cancer. It is also not only the pain management, it is not only for terminal illnesses, and it is also, all serious health related sufferings of patients along with the care of families. So it relieves the suffering and improves the quality of life of both the patient, of the life of the patient, as well as the quality of death of a patient. So this is in contrary to the popular belief of giving palliative care only for cancer patients, because it is mostly related to cancer. We can say we do palliative care mostly for cancer patients because of the fact that cancer has a immediate deleterious effects on people who has terminal cancer. In terms of a lot of symptomatology, in terms of patients showing a lot of deterioration over a very small period of time. So let us understand something very basic, uh, which will actually give us a hang of why how we should be approaching a patient with any health related suffering. So in when we see a patient with a disease, how do we differentiate between the disease of this patient and the illness of the patient? So you can see a picture where on the right hand side there's this patient who has through and through fistulous ulcer over the cheek, and if you concentrate on the picture, you can see the anxiety of this patient on his eyes. The ulcer is raw. There is a opening in the which gives way to inside the oral cavity. You can also see part of the lateral part of the tongue. So this is a 42-year-old manual laborer. He has a cancer of the cheek. He's living with his wife and two children of aged 9 and 5. He comes to you with pain and foul smelling wound. So now we want to understand what is the disease here and what is the illness. So for us as doctors, the disease is definitely the squamous cell carcinoma of the cheek, definitely after a biopsy report, and then a superadded bacterial infection of the whole ulcer, of the whole malignant ulcer. So this is for us is the disease. And when we talk about illness, uh, everything that comes under the disease plus the pain, a poor appetite because he's losing weight also, he's extremely tired all the time, the disfigurement that has been brought about by this particular ulcer, the foul smelling wound, which always oozes. He eats something that comes out of this fistula. He drinks something that also drools from the side, from the area which is, connected to the outer environment. And the question of getting socially alienated, from the community because of the fact that he has the foul smelling wound, and people would not generally come and you know uh, offer any help or talk to him, or he be included in any kind of community participation, or you can say anything which includes the whole society as a whole. So the questions of this person, what will happen to my family after I am gone? Why has God done this to me at all? So the whole of these questions, the problem of disfigurement and the smelling wound, the social alienation, everything actually comes to the whole spectrum of illness that this person has. we need to understand the suffering of the patient. And if we do not understand the suffering, we may not be able to realize or, perhaps internalize what is happening to this patient and how are we going to take care. We may not be understanding, the path for
Dr. Sanghamitra?
uh, getting this goals of care of the person. So we need to the suffering of the patient. So alleviation of suffering is one goal. We have to optimize the quality of life till the person is there. We need to have a provision of comfort in death, and for this, uh, uh, inadequately relieve suffering,
Dr.
will
Sanghamitra, sorry to
actually be
interrupt you.
undermining the values. Hello?
Ma'am, sorry to interrupt, but is it only for me that the sound was breaking a lot? Dr. Radha, could you please confirm?
It did break a bit. Now it is okay, Shri Priya. It did break a bit, but now it has become all right. In between, there was no voice, and then it has started coming now.
Okay, thank you, ma'am. Doctor, sorry to interrupt, Dr. Sanghamitra. You may please continue.
Yeah, can I continue?
Yes,
Hello?
sure. Yes, ma'am, sure.
You can hear me. Yeah, yeah. Okay, okay. So, you see, we have to understand that persistent and inadequately relieved suffering will lead to undermining the values of life for the sufferer. That means that if we are not clear with the goal of, you know, um, relieving suffering of this person and giving that particular uh, uh, symptom care, uh, pain management, symptomatic control, taking care of the rehabilitation issues of any kind of a patient who is generally slipping into terminality and perhaps going into the end of life of his whole problem, then we will not be able to, give him the best quality of life that is required at this point of time. At the same time, we will also have to understand that the alleviation of suffering is universally acknowledged as a cardinal goal of medical care. So, whatever we do, we become a cardiologist, we become an anesthetist, we become a surgeon, or an oncologist or a neurologist. The cardinal goal of medical care is universally accepted as the alleviation of suffering and nothing else. That is the only goal that a doctor or a nurse or a healthcare provider has, right? So this has to be taken into consideration while you try to understand the suffering of a patient, of a person who is, having, uh, who is perhaps your candidate for, palliative care. And having said all these things, we have to acknowledge that the ability to recognize suffering is an acquired skill. So when we say it is acquired skill, we need to understand that we have to develop this skill of understanding the suffering of these patients. If we do not do that, we will never be able to understand the suffering, as well as we will not be able to acquire the skill of, recognizing this particular suffering of the patient. So, where does actually palliative care start? Uh, in 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 a nutshell, when we talk about understanding the suffering of this patient, trying to provide that patient with some kind of treatment or therapy, or getting help from organizations, or getting help from colleagues who are in other specialties. So where does palliative care generally start? So the old concept generally tells us that uh, for a diagnosis of a terminal illness would actually prompt a doctor or a team of doctors to start life prolonging therapies for the patient. Um, After which this the prolonging therapy would actually go on and on and on till they find that the patient is actually slipping into a stage where this patient will be benefited by some kind of care which they term as end of life care, and that might not be as significant as the life prolonging therapies for them. And after some while, maybe, generally the old concept says that it would be around 4 to 5 days of, of life. And that will actually come to the end of everything, which will culminate in death. So this is the old concept, and this concept, uh, you will realize that uh, many people or many medical institutions still follow this particular old concept of giving some kind of care when nothing seems to work and they know that the patient may not be staying for another uh, few days or perhaps even few hours. But as healthcare professionals, uh, it's important that we realize that we all have a responsibility, and it really doesn't end with being able to cure or not to cure. The question of cure generally must not be an obstacle to giving our full responsibility, for care of any kind of patient, whether the patient is in a terminal stage or not. So the modern concept, as described by many stalwarts, mainly Cicely Saunders, and she said that uh, every every possible care, which will come under palliative care, has to start from the point of diagnosis, okay, of any kind of illness. As of now, it is any illness or any disease which has a serious health related suffering associated with it. And at the same time, terminal illnesses like cancer, HIV, AIDS, Parkinsonism, dementia, everything will actually need palliative care right at the point of diagnosis of such a disease. Having said this, we need to appreciate the fact that cancer as such, is generally detected. 80% of cancers are detected in a stage 4 disease or maybe in a stage 3 disease. But then those cancers that are detected at stage 1 are also, good candidates for starting palliative care. So palliative care would actually start at point of diagnosis. The role of palliative care as the disease progresses will increase. As you can see on the graph, the role shall take a very important place in the whole disease progression. And the disease, when I say disease progression, the disease may become stable at one point of time also. And if it is a disease which is actually going to culminate in terminality or incurability, then that might slip into the end of life care part, which may be around 3 to 6 months of the life of the patient, and that would generally stop all kind of life prolonging therapies, and the end of life shall comprise of palliative care principles as well as um, uh, you know uh, principles like withdrawing and withholding life support for a patient. And after death of this patient, we generally do not stop at that. We continue to do a bereavement care for this patient's family. We also try to extend help like rehabilitation, and try to find out ways and means of bringing this family out of the bereavement that this family is going through. So palliative care would for the modern concept would start at the point of diagnosis, take a higher role as the disease progresses, take the stop all kind of life prolonging therapies as the end of life ensues, and after that will extend into bereavement care. So this is the modern concept, and this is the take home message that you have to take today. So, if you see, in order to follow the modern concept of palliative care, we need to understand the importance of prognostication of a disease. Unless and until we understand how to prognosticate, we may not be able to explain it to ourselves why we need to start palliative care, and how are we going to explain it to our colleagues in other departments, to people who are family members of such patients. So we need to understand that the most important skills, clinical skills in medicine, are diagnosis, treatment, and prognosis. Okay, but uh, if you look at the history of development of modern medicine, you will agree that over the past 100 years, the prognosis of accompanying diseases, accompanying diagnosis. So that is an important factor which generally will tell us, how to keep prognostication as a priority when we diagnose and decide to treat a particular disease. So why should prognostication be important in palliative care? So the first and the foremost is we need to provide patients and their families with information so that they can set their goals, they can set priorities, and they can also set expectations of care. You know, uh, you'll always see that when you set expectations of care, they will, you will never be confused about how to go about it, and at the same time you will be able to clear out all the confusion that might arise in a kind of a case that is there for all of you, for all of the family members who are trying to get the patient the best possible outcome of the care. Secondly, you need to help patients develop insights into their dying. This is an important point because uh, in the Indian setup, and perhaps in many other setups that are prevalent today in other societies other than India also, patients are generally not being told about their diagnosis. You know, um, this is a protective mechanism of the family. This is also a protective mechanism of the treating physician, because of the fact that he or she would actually generally want the patient to be in a happy mood where he is not thinking about it, right? And that is where things generally go wrong in understanding the suffering of the patient. And you get all the wrong kind of vibes, you get all the negative kind of things that uh, take place in and around the care process of such patients. um, Generally, we as clinicians, we need to assist um, patients as well as their family members in decision making process, and that is where palliative care generally gives an importance to the whole process of decision making for patients, by patients, and by the family of the patient. Um, Also, to compare like patients with regard to outcomes. What would be the outcome? Not really talking about the ultimate outcome, but then suppose, for example, there's a patient with ascites and the abdomen is bloated, and he has a malignant ascitic problem, where you decide to give relief to this patient by doing an ascites tap. You have to communicate the outcome. And the outcome being that even after we do an ascites tapping, there might be a reaccumulation of fluid, within perhaps another 2 or 3 days. And that has to be an honest, communication to the patient and the family members, because they would actually always generally think that taking out the fluid from the abdomen of this patient will generally lead to cure or permanent relief of suffering for their patient. So this was just an example. Also, we need to provide a common language for healthcare professionals who are involved in the end of life care. So, as you travel through the whole course of this particular fellowship offered by Pallium India, you will also come to know that while we deliver end of life care or palliative care to our patients, we generally we would like to work in a multidisciplinary and interdisciplinary team, so that uh, we can take help from our professionals who are involved in the whole care process. So this is why prognostication in palliative care is extremely important. Uh, Prognosis is generally defined as the relative probabilities of the various outcomes of the natural history of a disease, right? So you all will agree with that. So Price and Ehrlich actually gave us 5 Ds of prognostication, which generally fits in so many situations that we will come across while dealing with palliative care. So the first D would be disease progression or recurrence. For example, as I said, how quickly will the ascitic fluid reaccumulate after a tapping? The second D is stands for death. How long have I got? This is a very common question put forward by a patient who's suffering from a terminal illness. And as palliative care physicians, we need to give this very clear understanding of the fact that this patient may not be able to stay for another 6 months. And this is actually you'll learn in your communication skills how we need to deliver this particular message to the patient as well as to the family. And the numerous benefits of giving this prognostication to our patients, including the time frame for them to wind up their own business, their own work, their own goals of their lives. Talking about disability, will I walk again, or will I be able to, if the patient is a sprinter or somebody who's actually involved in sports, how would I reassemble myself? Being a Olympian, will I become a para Olympian? These questions are very important when we talk about disability. The fourth B is, of course, drug toxicity. Will I get addicted to morphine? Because suppose we are dealing with cancer patients and we are very, very extremely liberal when we use opioids. And morphine being a natural opioid and the most, the cheapest of all, we are into, providing opioids to our patients on a very liberal manner. And we need to find out certain ways of telling this patient that this, with morphine, there is no fear of addiction. At the same time, we have to empower our colleagues who are going to, write morphine, that they must not have any kind of opioid phobia. And then the last one is, of course, the cost. It's written as dollar cost, but definitely the cost of palliative care. Trying to get a comparison about the whether conventional care is more expensive than palliative care. Does palliative care gives the patient a benefit of doubt when he is trying to use his resources more properly or in a justified manner? So these are the 5 Ds of prognostication. And as such, prognostication is definitely one of the most important armor, if I may say so, when we deal with patients. Few pictures that I've got for all of you to see. What is it actually like to be in pain or in suffering? These are my own real patients, and they all have actually passed away. Everybody in a terminal stage. If you can see this picture, you'll feel what this patient is going through, because this was, of course, during my own training period. Unfortunately, there are instances where we are really not able to completely relieve the patient of his or her suffering. And this one is an example where the patient has suffered from cancer of the penis and had to stand all the time to relieve his pain. You can see this is a very young patient, around 16, 17 years of age. You can see what has happened to this person. I mean, it will be impossible for any of us to imagine ourselves in this position. So that is what I mean by trying to understand the suffering of people. If we understand the suffering of people, it's going to make us a bit, a better person, better people to deal with their suffering. Not only just trying to give medication, but also be compassionate and show them a path where their suffering is relieved, or up to some extent, at least up to some extent. So these have been all patients with different diseases. Everybody having their own course of disease, own course of dealing with their physical suffering as well as other things that are important. So this brings us to something that has been coined as total pain. And when we talk about total pain, it is just not only the physical pain, but of course, the spiritual, emotional, and social aspect also. Physical pain, you'll always be able to recognize physical pain. Usually, they need treatment. For example, with drugs, they have variable degrees of distress, and they interfere with other aspects of life as well. But the spiritual, emotional, and social aspects are even more difficult to deal with because they pose you with certain kind of questions which we will never ever have an answer to, and that would actually demotivate us. That would actually pull us down. But having said this, uh, you know, uh, the only thing that the patient needs is a patient hearing from you, a ear to hear, a shoulder to cry on. That is what you have to do, because we do not have answers to all questions. We also do not have, a proper plan to give them so that they are totally, out of spiritual, emotional, or social pain. But yes, of course, uh, if we are if we are able to acknowledge what they are going through, if we are again able to understand their suffering, perhaps this would actually give give the patient a lot of relief, lot of confidence that there's somebody who has listened to me. There's somebody who has understood what I'm going through. So palliative care for physicians and nurses, it is not just understanding their suffering and giving them a shoulder to cry, but it is also active medicine. We do scientific evaluation of physical problems of like pain. We take care of terminal breathlessness. We also take care of neurological symptoms. We also take care of a lot more physical suffering that come in a way that actually surface out during the end of life of a patient. So as I said, physical symptoms like pain, they are just the tip of the iceberg, and everything else actually are deep embedded inside. But one thing is for sure, when you also start practicing as a full-time palliative or a part-time palliative physician, you will realize that when you take care of the physical symptoms, the Pandora's box is open, and everything that is inside will actually slowly surface out. All you have to do is to acknowledge the issues of these patients, and that is going to give them a huge amount of relief. So there was this World Health Assembly, which that was held in 24th of May 2014, and they have given a very important thing, that says that we need to acknowledge that palliative care is an ethical responsibility of health systems, and that it is the ethical duty of healthcare professionals to alleviate pain and suffering, whether physical, psychosocial, or spiritual, irrespective of whether the disease or condition can be cured. And that end of life care for individuals is among the critical components of palliative care. So this is where the 64th World Health Assembly had, given this very, historical statement about the critical components of palliative care to be included and to be taken as ethical responsibility of the healthcare system. So, what are the implications in serious diseases like cancer? We have to understand these facts that the current cancer prevalence in India is around 2.5 billion. So you can imagine the kind of load that one cancer hospital has, in a small locality, right? New cancer patients that are registered annually is 9.9 million. The deaths due to cancer annually is 0.5 million. 2/3 of cancer patients present in stage 3 and stage 4, and that is advanced cancer. And they will definitely need palliative care. But having said this, stage 1, stage 2, or any cancer that comes in any stage of the disease definitely will be benefited by palliative care. We have an aging population. Our great Prime Minister might be actually giving us this very notion that India is young India, but unfortunately, the young is going to become old in another 10 to 12 years, and that would be aging population for India. So it has about 100 million elderly right now, and it is expected to increase by 324 million by 2020, and that would constitute a total of 20% of the whole population of India. So you can imagine the palliative care that is related to elderly care. That is one, and secondly, 60% of our elderly are affected by cancer. So these are not my statements; these are facts, as I have actually acknowledged. These are reports by DESA, United Nations. The most important thing that we generally face while delivering palliative care, why we have late reference to palliative care is opiophobia, the the fear of addiction, which is there inside every doctor, and that leads to a lot of unrelieved suffering. Undertreated cancer pain in India is 1 million people suffer from undertreated cancer pain. 0.4% of patients with cancer pain have no access to oral morphine. That is this is a disastrous situation because of the fact that India is one of the largest producer of morphine, but every thing is actually 1/3 of the whole thing is being exported outside, abroad. We sell them to other countries, but and that's the reason why our people back home do not get the important pain relief that is needed. And this particular statement by the National Crime Records Bureau, this report came out in 2013, and it says that more than 25,000 suicides that happened in 2013 were due to various ailments, and hanging being the preferred choice of ending lives of these people. And they chosen it because of the unrelieved suffering that they go through, because of maybe because of terminal cancer, maybe because of suffering that is related to their health condition. So it is important that we need to acknowledge everything here for these patients and try to bring about a change in the attitudes of doctors and healthcare professionals towards using opioids for cancer patients and other, aspects of treatment of, health-related suffering. So there has been a lot of, civil society-driven drug policy reforms in, in the last few years, and that has actually um, brought about a lot of changes, a positive, lot of changes. And so the present Indian scenario is that we have a national program for palliative care, and it was created in 2012. You can actually go to the website of the Health and Family Welfare Government of India. You can find how to bring about or implement the National Program for Palliative Care if you are into, if you are a government employed doctor. And then the great change that has actually, has been brought about by a lot of effort from the palliative care stalwarts, mainly headed by Dr. Rajagopal, has brought about a change in the NDPS Act. It was a draconian NDPS Act which had a lot of problems in, access to essential narcotic drugs, mainly morphine. But now this has been changed, and the new NDPS Act has been enforced from 2014, and that has greatly improved the access to oral morphine and other opioids too. Regarding education and training in palliative care, uh, fortunately now we have a lot of courses, including the MD and DNB in palliative care, also palliative medicine. And there are many centers. I have mentioned only a few, but many centers are there who are offering MD in palliative medicine, as well as they also started DNV in palliative medicine. So anybody who wants to take up palliative medicine as their career are, most welcome to join DNB or MD. At the same time, generalist palliative care, courses are being offered by Pallium India, the Institute of Palliative Medicine in Calicut. There are many volunteer courses on community palliative care. There are many courses on nursing also, which I have actually forgotten to mention here. But now we have a whole load of, courses that are being offered by many good institutes in India. So the big question for us right now, do we actually want to end our lives, or land up in a situation that this person is, or do we want something like this to happen? So it's up to you to decide on what we want to do. Are we going to implement palliative care, take this message today back home, and try to figure out, our place in palliative care? Because I believe that palliative care is everybody's business. It is not just doctors or professionals. It is everyone. Everybody will have their own little bit of contribution in bringing about relief to people who need it the most. So, just to end my presentation today, I would like to tell you that this is a African proverb that has really impacted me a lot in my career also. And it says that if you think that you are too small to make a difference, then you have obviously never ever slept in the same room as a mosquito. So I end my presentation here, and I'm really a lot of apologies for all the disturbance that has happened today while delivering this very important topic to you. And equally thanking Sri Priya and Radha Madam for bearing with me today, and all the participants for giving me a patient hearing. So thank you, Shri Priya. Over to you. Thank you.
Thank you, Dr. Sanghamitra. I'm extremely sorry. I'm keeping my video off for some time because of health issues. Thank you, doctor, because we could realize that you have not like winded up your day, busy day yet, and still you found out time. And thank you so much for walking us through that brilliant session. Dr. Radha?
Big thank you, madam, for covering what, how, when palliative care should be delivered. Excellent. You've covered everything. That is what is essential for all of you to take home. And as she mentioned, the diagram which said where it starts at diagnosis, okay, and goes hand in hand. So at diagnosis, it's in the background to say that we are there to help you. Then as the disease or whatever thing goes on with the patient, it's a multimodal management. We are there to help you all the time. And then whenever needed, it comes in, provides the best care. Not only the patient, family, carer, everyone is looked after. So every slide and everything is important. So that is what is to be understood. It's a multimodal management. It's just, as she mentioned, it's physio, psycho. We have seen so many elements are there. The patient as such, along with the patient's physical, mental, social problems, the family as such, and the carer equally have to be considered. So that's, as I said, how, where, when, everything we have seen with it. And then that is how it goes. So anyone has any queries, questions, either you can go on to the chat box and type. So already you have mentioned some. So if you want to raise questions, either you type in the chat box or you can unmute and ask, and then we will go on. We'll have a discussion. Any burning queries, questions that you want to ask. And then after that, we'll go into the case presentation.
Do we have any quick questions to take up before we move on to the case presentation?
Either if you have, go ahead and type or unmute and ask. Otherwise, we can go into the case presentation and combine everything and have the discussion too. Will that be okay?
Yes, ma'am. I think
yes,
we can move ahead with the case presentation.
Yes,
so just a brief, before we move on, today's case presentation will be done by the team from Palliative India. We have a doctor, Dr. Grishma, joining us to walk us through the case. And based on this, you will get an idea how to bring in your case scenarios and present them during the sessions. So we are just moving on to the case presentation. Dr. Grishma.
Thank you, Sripriya. Good evening, everyone. So let's see one case. 39-year-old male. Diagnosis is traumatic quadriparesis with stage 4 pressure sore on sacral region and left gluteal region. Presenting complaints are 2 days constipation, bed sore over sacral region and gluteal region, moderate pain over hip region and urinary leakage. History of illness, he had a history of fall while carrying weight followed by neck pain and weakness of both limbs and was diagnosed with traumatic quadriparesis in August 2015. He was admitted and got treatment from one of the government hospital and discharged after 1 month. After 6 months, he developed a bed sore over sacral region and gluteal region, which was stage 4, and history of pain over hip and wound site for more than 2 weeks. Pain over the hip region, which was intermittent burning type of pain on both hips, score is 5/10, and at the wound site, the score is 4/10, and it is continuous throbbing type of pain. Due to this, sometimes they keep the wound open. Okay, and the sleep was very much disturbed and decreased oral intake. On examination, he was conscious oriented, febrile, pulse rate 82, respiratory rate 20, BP 120/70, systems are within normal limits. Local examination at the pressure sore site. There was warmth and tenderness. Exudates were present. Tunneling were present. That was irregular in shape, and foul smelling was also present. So we have done a routine investigation, and hemoglobin was 10, total count 34,000. Neutrophils 80, lymphocytes 18, eosinophils 2, platelet count was 1.6 lakhs, and serum creatinine was 0.9, and sodium 132, and potassium 4. And psychosocial aspects we explored, and it was 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one siblings, and he's married and living separately and not caring and helping them. He was a manual laborer, and he was the breadwinner of his family. Because since he is bedridden, his mother is now taking care of him. She is a manual laborer. Now the main source of income is from mother's daily wages and her pension, and some of his friends also support him. Have taken 1.5 lakhs from private finance bank for treatment purpose. He was a devotee and now not able to go to church, and this makes him very sad, and he communicates through all these things through cell phone to his friends and all. He used to say to his mother, like, I don't think I can walk, so please don't spend money over my treatment. And main concerns were pressure sore, pain, and financial problems. Summary: 39-year-old man with traumatic artery paralysis with bed sore present over sacral and gluteal region, stage 4, and pain over the hip region. Our discussion points are: do we need to provide palliative care for this patient? It's a case of pressure sore. So next, what are the problems faced by this patient? What all can be done for this patient and his mother? Okay. Thank you all. Have a good discussion with Madam. Okay. Thank you, Srithya.
Thank you, Dr. Grishma, for bringing in that case. Now I think we can open up the discussion points for the audience, right, Radha?
Exactly. All of you have a thing. Important questions are there. Okay. And we have had a lovely informative talk also on what is palliative care. So we can take it from here. As I mentioned before, either you can type it on the chat in the chat box, or unmute and ask. There are some questions in the... Just a minute. I'm just going to answer the questions which are there, Sripriya, so that nothing is missed. I think first one is, what is the difference between palliative care and end-of-life care? See, again and again, I'm going to go to the same graph that which had the yellow and purple one. So palliative care starts from the beginning. It goes hand in hand with the definitive care, and delivers both. End-of-life care is one which is part of palliative care. Okay, so like it is inside the main. So end-of-life care is part of palliative care. So I think that is the answer for that. How does palliative care usually start? Wanted to confirm. So basically, from my personal experience of working in Cancer Institute, as soon as a patient checks in or comes into the hospital and has the diagnosis itself, we had informed them to refer them if they feel that the palliative care. So there was a pain in palliative care. So most of the next thing what I would try to mention here is palliative care as such could be hospital-based care and home care. Okay, so hospital-based care is going to be if you have all the resources and everything there, you have the facility and ability to have all under one roof. So that is one type. Either you have in one hospital which has palliative care as inbuilt with the curative care, or it could be an additional service. It could be a home care team where they could go in person to because some areas may not be accessible or the patient may not be able to come. So it could be very many reasons. So home care is another part of it. So how long does palliative care usually last? As I said, it goes on depending on the nature of illness and your loved one's circumstances. This final stage period may last from exactly. It can be from few, as it was mentioned, 3 to 6 months is the normal thing we say. And see, this answer alone, there's no definitive answer. So we have to go ask for the patients. So always reassessment is what will give us an idea for us to raise awareness to the patient and answer their queries. As part of palliative care, terminal illness can be a long one. Yes. What are the best ways of providing palliative care outside of working hours to avoid crisis and help? See, telephone service, something like that is now. Many centers do have telephone service availability. They may have a nurse at least now to answer that, and then the nurse could get in touch with the medical team. I think Palimo India also has got a telephone service. Is that right, Sri Priya? You do have a.
Yes, ma'am. We do have a telehealth line.
Yeah. Yes. So that's what. So I'm just double checking with you. That's all. So I am aware. So that is one option also there. And this telephone service does help a lot. Okay. And wait. So I'm just making sure I'm covering everything. 1 minute. Okay. What are the benefits of advanced care planning and other approaches? See, those things will be dealt with separately in other sessions also. See, advanced care planning and all depends on what, if the patient has something in mind, we are giving autonomy to the patient to say, this is what I like and this is what I would prefer to have. So those are things. In those type of situations, the beneficiary is both. The patient also gets benefited and is happy that things go on the way that the patient wants. And then it gives the treating team also a clear plan of action. So that one you will be dealing in when we go into ethics and legal issues. We have few sessions which will cover that also. This is called out of hours. You may have to organize your time and dedicate time. What is that? I think Sanghamitra madam has replied to that.
Yes. Actually, she had taken up a couple of questions while we were going through the case presentation, and she was generous enough to answer them.
Yeah, exactly. Now only I saw that. She has also mentioned about that. This continuity of patient line. That also she has answered. What are the best ways to access street pain discomfort? Yes, she has given see, there are motor neuron disease, dementia. That's what you have specific approaches for particular disease based. You have additional information. Madam has given some more information also. Financial help. Financial help again. No, there are so many organizations who will be so the palliative care team, if they can have meetings with social care or the community services which are willing to help. So having a hand-in-hand meetings or something like that does help. It could be a monthly meeting, something like that, which could help.
Ma'am, I have a doubt, ma'am. How do you approach I'm a pediatrician basically. Suppose if the child is, for example, a cerebral palsy child, whom the home-based care is important, how do you explain it to the patients, to the parents who are little below poverty line and uneducated?
See, the financial element and those things, awareness. First thing is that it will take matter of time, dear, as you have asked. In one sitting or one meeting, you will not be able to convey everything, because first thing, there is enough and more information. Okay, there's loads to be conveyed, and then the family or the parents will always be in a phase of denial. Always, I want to hear what I want to hear. Okay, I don't want to hear what is not nice. So we normally say it will take few meetings. First, they will, that you're breaking the ice. Okay. So at some stage, what is the important thing we have to observe there? We will be doing the same talking, but one day you will see the difference at the receiving end. Who were in a phase of denial will change gradually. You have to pick up that change and utilize that opportunity to tell what it is. It may be third sitting, it may be fifth sitting, something like that. So at that point, you give some information and then tell them, come back and think about it. And come back again, I will spend time, and then it'll be a totally different experience. Only time will give you. This is what is gaining rapport. It'll be the same it'll be the same person. But as you keep on telling, they will they will understand reality and it will bloom. That they will understand. And at that point, what you do, there only empathy comes. So you say that I do understand your difficulty, and now I will give you options. You then think about it. So it is for your benefit and for the patient's benefit. So it will in matter of time, it will work.
Thank you, ma'am.
Welcome. Okay, go ahead. Anything else? Okay, coming now to this case as such. See, this is a very lovely, it's a case which has got the elements which we need to look into. First, let us just try answering the question. Do we need to provide palliative care for the patient? Yes is the answer. Anyone having a different opinion, please speak up. Oh, okay. The next thing is, what are the problems faced by this patient? See, first thing is that he is by himself, and whatever the injury that he had has made him to a state where he's unable to care for himself. He was the breadwinner for the family. He was looking after himself and his mother. But now he's in a state where he is unable to look after himself in the first place, and then his mother. And so basically, this is pressure source because of lack of movement. Again, here importance is we have to teach them rolling, taking care of the pressure points, teaching them what are the pressure points, how to avoid pressure source. Then big important chunk is nursing care. Teaching them how to nurse and heal the wound. So those are the things. And then along with that, we have to, as Madam mentioned, the iceberg, it's just not his physical pain. His mental, social, psychological, every element is there. He is so depressed. He is not keen on living. So many other things. So what are the things that could be? So getting some counseling or psychological support for him if possible, and encouraging him. And so because sometimes with the support and things, teaching him or giving facility to do nursing care, teaching the mother to help him. Those are the options for that. And then what all can be done for this patient and his mother. So trying to develop a better relationship between both of them. See, the boy, when he could work, he was looking after the mother. Now he need not feel. So whatever, building a better relationship between both of them so that they both enjoy the company of each other and then help each other, whatever is possible. And then giving some respite care for the mother also. If mother is the only carer all the time, then she also will be, she is an old person compared to him. So those are the things which have to be considered individually when you go into these aspects. Anything else?
I felt one more thing was he's interested in going out to who was a regular church goer.
Yes,
so
yes.
Something we need to do about that so that he mentally spiritual impact will be a little better for him, which keeps him psychologically better. And then the second thing is basically his feeling of financial dependence on the mother. So like to feel as if like dependent on somebody, for a person who was already working for a long duration to suddenly become dependent, so that to be addressed to the patient. And other thing is, as you said, ma'am, the relationship between both of the mother and the patient is required.
Yes, very important point. As you mentioned, spirituality, they have plenty of studies have shown if someone has a spiritual background, that helps those type of people to deal with their palliative care situation well. So we can see if someone from church could come and talk to him. So that is something which you could think, because sometimes some nurses, someone from the church, some sisters or from the church may be willing to be able to come once in a week or something, do some prayers with him. So he will also feel, like when they go to church on Sunday, they may pop around, come and spend few minutes with him. So something like that will make him feel better. So that is one thing. And then with the financial element, if something could be helped and done, as I said, some of the social NGO service could be contacted and done. And one more question, which was on the chat with training staff and things. No, first is training, retraining. That is what is needed. And whatever training is available locally. See, we have to see what is possible and feasible. It'll be best to have maximum manpower, best to have everyone up to the mark training, but always see what is available in your area, what can be provided. Try to see what is achievable and then try to get it. And the difference between hospice and palliative care, see, hospice is mostly only having end-of-life care. Whereas palliative care is, from today what we know, palliative care is a run-through care. From diagnosis, after bereavement also. So hospice is just something which is provided at the time of end-of-life care. That, as someone has mentioned, financial help with NGO, that is something, it is a bit of a challenge. But see, many hospitals and centers have social workers. So those social workers could be used as a link to help the connect or link the patient and the social NGO services which are available in each area. So that is something, because everywhere there are social workers working hand in hand with the palliative care team. So if there is a possibility to link them, that might come handy for, see, this patient is one. Many situations you may see where there may be someone who has children who need financial support for their education. See, it is the patient we have. That's our main aim and goal to treat. And you have the surrounding family also all along. So we have to have that in mind also.
Yeah, that's why I've asked that question actually, because we see many patients, all of them are ready to help as far as the psychosocial aspects are concerned. Emotional quotient is being taken care of, but many a times we are stuck up at finances. Many a times we are not able to arrange that as much as is required. So that's why I said if we have an official tie-up with the NGOs, that would help actually,
Exactly. That is I try level best every time I try to convey, because it's a bit of an extra work. I don't deny it's not easy. That is the toughest bit.
True.
And so if we can see, many times you may have to work a little bit more, find out if there is any organization, someone, because the organization, maybe they're willing to help. So, and we have the person who needs it. So if the link is made, something could help. I know everything needs, you have to go a bit of an extra mile. I know a bit more effort. And ultimately, if someone is going to benefit, that is what we are looking.
Thank you so much.
Sri Priya, how are we for time?
Ma'am, if there are more queries, we can take up maybe 5 to 10 minutes more.
Okay.
Because this being the first session, we may need to
we have to give an introduction of other things also you have mentioned. There's a question which I will have a read. 69-year-old patient with metastatic breast cancer was brought to see you by family who complained that she'd been confused and restless, wanting to go to work, singing songs loudly and getting.
Ma'am, I think maybe we can ask Dr. Abhishek to send it as a case scenario so that we can discuss
That's
in
what
detail.
this has got. Exactly. This one, no, is it has multiple components in it. So maybe he can, as you mentioned, we can take it for a discussion itself. Okay, because putting things into. I've been taking turns to care for her and I've been coping adequately so far. What might be appropriate? Metastatic breast cancer. So this is depends on, like, she's got multiple elements in it. So we could take it as a we can take it as a case itself because it has got multiple elements. Metastatic. How is her pain? We have to go into everything and see, and so that we develop best care for her. Okay, will that be okay, Dr. Abhishek? Is that right? No, over to you, Sri Priya, if you want.